Hydrodissection in the posterior capsule with focal dense white opacity and thick central plaques. Hydrodissection is widely accepted as a routine surgical step for cataract surgery. A good hydrodissection makes the nucleus rotate very easily. An incomplete hydrodissection can damage zonules and bag for the following procedure. However, posterior capsule with focal dense white opacity and thick central plaques are a nightmare for many cataract surgeons because of the high expectation of posterior capsule rupture following hydrodissection. Why feel nervous about performing hydrodissection in the posterior capsule with focal dense white opacity and thick central plaques? Making a successful hydrodissection in regular cases is easy for most surgeons. But in unusual cases, like the posterior capsule with focal dense white opacity and thick central plaques, they will prefer not to do the same procedure. Therefore, different surgical techniques were created to manage those challenging cases due to the fact that it might increase the incidence of posterior capsular rupture. It seems that the high incidence of posterior capsule rupture during surgery for those unusual cases might be because of three reasons. Firstly, there might be tight adherence of the dense white opacity. Secondly, the posterior capsule itself underlying the thick central plaques is extremely thin. Thirdly, it increases the risk factors for occurrence of intraoperative rupture of the capsule during unfamiliar hydro or hydro-free procedure performed by inexperienced or anxious surgeons. Hydrodissection is a small but very important step to mobilize the nucleus within the capsule in achieving successful phacoemulsification. Once it is performed, the entire lens cortex is separated from the lens capsule by balanced saline solution. We use a 27-gauge disposable cannula attached to a 1 milliliter syringe. I hold the syringe in my non-dominant left hand and firmly but lightly push the plunger to eject a small quantity of BSS out of the syringe in the right hand until a fluid wave can be seen traversing the pupil inside the posterior capsular bag. The nucleus is rotated within the capsule using a 27-gauge cannula, and the motion is akin to rotating the steering wheel of a car. It should be performed gently to minimize the stretch on the zonules and creates a cleavage between peripheral loose cortex and the inner firm cortex. Most surgeons can successfully perform hydrodissection in normal cases, but it might be difficult to deal with posterior capsule with focal dense white opacity and thick central plaques, as well as posterior polar cataracts, because they were under great stress. We performed hydrodissection throughout the posterior capsule with focal dense white opacity and thick central plaques, and no posterior capsule rupture was noted during the hydrodissection and rotation of the nucleus. Here, we are going to simplify the action with extreme slow speed divided into 4 steps. Step 1. Cleaving the cortex from the posterior capsule. I used a single-point BSS injection. First, insert the 27-gauge cannula under the anterior capsule by slightly lifting the capsulorhexis edge upward. Second, less than 0.2 cc of BSS must be injected quickly and decisively in order to generate sufficient hydrostatic force. The force is proportional to the rate of flow and the cannula resistance. A 1 milliliter syringe is good to provide tactile feedback regarding the rate of flow, but surgeons with less hand strength may use a 3 milliliter syringe. We can see a fluid wave pass across the posterior opacity area. Step 2. Terminate the injection once the hydrodissection wave has completely crossed. We saw a fluid wave transmit across the posterior opacity area and stop the injection once the wave passed close to the lens equator. Sometimes, a slight forward bulge of the lens was also noted. That is a sign indicating that a large quantity of BSS has collected between the lens and the posterior capsule. Intraoperative capsular block may occur due to accumulation of BSS between the posterior capsule of the bag and the lens nucleus. This situation can cause posterior capsular rupture with the lens dropping towards the vitreous chamber. Step 3. Using the tip of the cannula, gently depress the lens. Gently depress to separate the nucleus from the anterior capsule and to vent the fluid out. The cleavage of cortex from the capsule equatorially and anterior capsule allows fluid to exit from the capsular bag via the capsular excess. This action can reduce the BSS through the weakened central area of attachment between the posterior capsule and the lenticular opacity. Also, it can release the equatorial part of the lens from the capsule. Step 4. Rotate the nucleus within the bag using the cannula tip. Imagine there is a point on the axis of the lens. Rotate the nucleus around the fixed central point within the capsule in a counterclockwise direction. Pass the tip of the cannula under the right edge of the nucleus and hold it slightly lifted up in a plane slightly forward to the anterior chamber. This maneuver separates the peripheral cortex from the inner cortex. To reduce the risk of posterior capsule rupture, while performing phaco-chop, minimal stress should be applied on the capsular bag. A central circular hole was visible within the posterior capsule, consistent with the attachment between the lens opacity and the posterior capsule. We believe that the posterior capsule with focal dense white opacity and thick central plaques is thin and weaker than a normal capsule. Gentler maneuvering of the steps we present will help avoid unnecessary downward pressure on the posterior capsule. A tiny amount of BSS hydrodissection can pass through the tight adherence of the polar opacity and the thin posterior capsule, which can minimize posterior capsule stress while performing the posterior polar cataract surgery. Therefore, a thoughtful hydrodissection reduces the risk of posterior capsular rupture, exactly the same hydrodissection technique that we used in our standard cataract surgery. Our experience showed that a very simple alternative approach decreases the incidence of posterior capsule rupture, even in posterior polar cataracts. It is also effective in reducing surgeons' intraoperative stress and anxiety during management of posterior polar cataracts.